Before we get started, I just wanted to take care of a couple of house cleaning items. So first of all, just a reminder that lunch will be served from 12 p.m. to 12:30 in ballrooms A, B, and C. Dr. Gary Green will begin his keynote lecture, Past, Present, and Future of Anti-Doping and Performance-Enhancing Drugs in Sports at 12:30 p.m. Scott Rigsby, the first double amputee Ironman winner, author of Unthinkable, and Twyla Bird, editor editor of the book with Refugee Stories, Let Me Tell You My Story. Their story is all our story. And that's all I have. I don't know. But anyway, I think those will be coming up at 12:30. So for right now, we'd like to introduce Brent C. James, who is lecturing on bringing healthcare to world with statistics. We'd like to thank Edith D. Green Foundation for sponsoring his lecture. With that, we'd like to introduce Mr. James. Thanks.
Thank you. Good to see you. I have to tell you, it's a real delight. Since Intermountain threw me out, I've been on the road a lot, and I spend an awful lot of times with various medical groups all around the country and around the world a bit. It's so good to see so many of my friends. I don't know if I can properly describe it. What fun. The second thing, though, I've been here before, and always I come behind a really interesting lecture, and after you've heard something like you just heard, then to get me, I mean, this is just to make people eager for lunch, I figure. On the other hand, my job today is to look a little bit into a crystal ball. And as usual, crystal ball gazing is a little bit difficult. Predict that in Nostradamus sort of a thing. On the other hand, I think that there are some clear signs of how our profession is moving. And in talking about changes that are happening around the world and within this country, in our own local community, I think there are some real signs that we could see, and I thought to share those with you, and hopefully not get it too far wrong. Have a little time at the end where we can argue about it, debate it a little bit, if some of this stuff needs some debate. The best way I know to frame it, though, it all happened for me. What really got me on this track happened a long time ago, way back in 1986. I was at the Dana-Farber Cancer Institute in Boston. I had a faculty appointment at the Harvard School of Public Health. I was a classic academic physician. I participated in the largest multi-center trials group in the world. It was the Eastern Cooperative Oncology Group. We had about 450 contributing academic medical centers scattered around the world, mostly here in the U.S. I was over GI tumors. Matched my background training, originally surgical oncology. I'd just come from spending 5 years at the College of Surgeons and the Commission on Cancer. Before that, NCI, National Cancer Institute, for a little bit of research time there. I had about typically, any given point in time, between 4 and 8 randomized controlled trials running around new therapies for GI cancers. It's the funniest thing. Because of my institutional association and because of my publication history, when they held consensus conferences calling together the experts around how we ought to address GI cancers, I got invited fairly routinely, you see. I was regarded as a national expert around those cancers. Here's why it's funny. It's like I lived in two worlds. Most of my time was spent doing research. I had a set of very rigorous mathematical tools, approaches, statistics really, that I used to approach that. It's all about causal linkages. How could we reliably say, if I do this, then I'll get that? Very rigorous, built up over the years, a high standard, and we were held to it fairly tightly. Then I'd take a few minutes occasionally and go actually care for a patient. Actually practice a little medicine. Here's the trick. It was high quality care because these hands did it. I was the respected authority. Doesn't that guarantee that the care I deliver is the best possible care in the world? That's certainly the attitude we all had. Just ask any of us. We would have told you that we were the best in the world because of that. What happened to me was a little bit of a personal tragedy. I suddenly became a single parent. It was just me and my 3-year-old. I moved back to Utah mostly to get closer to family. took this job at Intermountain kind of sight unseen. You know, it's funny. This really is true. I didn't know that administration existed. I really didn't. And here I am, a classic academic physician, a researcher, dumped in to the administration of a big healthcare system. I mean, it was hard on both sides, in all fairness. It took me a couple of months to figure out that I'd joined the dark side and didn't even know they'd issued a helmet, but there you go. So, yeah, here's the funny thing, though. What happened to me? What really happened is we took those rigorous measurement tools of clinical research and swung that spotlight to focus on care delivery performance. And when we did, we got the surprise of our lives. It turns out that belief that I was delivering high quality care because of my credentials, because of my experience, because of my publication history, simply was not true. It didn't stand up to careful measurement and evaluation. One way to just summarize that for you, in the run-up to the ACA, Obamacare, I was asked to testify 4 times to various congressional committees. Now, the committee of record that really controls health policy for the United States is Senate Finance. It was chaired by Max Baucus from Montana at the time, a Democrat. What I was trying to do was take a literature associated with this, a literature really centered around variation in care delivery, and make it accessible, understandable for a group of intelligent lay people with no clinical background. This is what I gave them. Now, I have to frame it in a particular way. So the framing, it is easy, almost trivially easy to demonstrate on the evidence that care delivery today is the best the world has ever seen. Dramatically better than any previous generation of people living on this planet have experienced in terms of the outcomes we achieve. Dramatically better. And frankly, if you look at it the right way in terms of actual care delivery, we're the best in the world. All right? All the verbiage to the side, that's a provable statement. Okay? We routinely achieve miracles. And the science behind that's unassailable. The trick is, it's the duty of every generation of the healing professions, of which we're a part. We commit to pass along something better to the next generation than we ourselves received. And the first step in doing that is to figure out where you fall short of your theoretic potential. Now, I've labeled that on this slide fairly carefully. And by the way, that's exactly how I presented it to those Congress people, to the senators and representatives when I testified. Exactly how I presented it, and they got it. They could tell me afterwards that they'd understood it. Of course, what they did with it was then use this list to go out and say that healthcare was broken, which I found to be really, really annoying and fundamentally dishonest. For something to be broken, somewhere, sometime it had to work correctly. Fair enough? I mean, it's working, then it breaks, and it's broken. There is not an instance in all the world of it working correctly relative to this list. Oh, we invest much more heavily in research here in the United States, but speaking about statistics for the world, same list in Sweden, one of my favorite socialized medicine systems, same list in Canada, Australia, Singapore, Scotland, Great Britain, Germany, Netherlands, same list around the world. They don't have as much evidence as we have, but I have sufficient to make that statement reliably. Small differences, but nothing substantive. It turns out that this list of opportunities lies not in health policy, but in how we conceive ourselves as health professionals, how we execute as physicians and also as nurses, pharmacists, therapists. I just wanted to run the list quickly for you. Many of you have heard it before, but I thought it might be interesting to look at it. For me, it describes where I lived every day when I was trying to be a good physician. Number one, top of the list, is just variation in clinical practices. People like Jack Wenberg, who show these dramatic differences from community to community. After adjusting for the underlying populations, differences in the rates at which people are hospitalized for treatment. Now for some things, there's no variation. Inguinal herniorrhaphy, similar across the free world. Total hip arthroplasty following hip fracture, no differences. But for other things, hospitalization for heart failure, hysterectomy, whole series of things, these dramatic, large differences. It's very professionally challenging. The reason is the variations are so large, it implies that we don't have a clue about what actually works. It's very clear that we couldn't possibly be delivering good care to all patients. That's a problem with the thing. Oh, Wemberg demonstrated that where you go to receive care is more important than whether you have insurance. It dominates the insurance question, interestingly enough. I mean, it's that extreme. Fascinating. Now, when we discovered that, and it was well documented, some other people had an idea. They said, well, maybe the reason for the variation in use rates across communities is inappropriate care. Inappropriate care, their definition was completely clinical. They judged care to be inappropriate if the risk inherent in a treatment outweighed any potential benefit to the patient. No money considered at all, pure medical. This in a profession that holds our primary maxim, first do no harm. These would be areas where we put patients actively in harm's way, to the patient's detriment. Well, a series of carefully structured studies around that, two major findings out of that body of research. First finding, it turns out that inappropriate care does not explain variation. You go to a low utilization community for a particular treatment, measure the rate of inappropriate care. Compare it to a high utilization community. Same metrics for inappropriate care. On average, they were about the same. Implication, we undertreat as much as we overtreat, is the implication of that. A secondary finding, though, that was much more deeply challenging in that initial set of studies, mostly from Rand, by the way, the high water mark was carotid endarterectomy. 32% of all carotid endarterectomies performed, judged on careful review by one's peers to be clinically inappropriate. The risk outweighed any potential benefit. It should never have been undertaken, but we did it. As a profession, it was done. It gets worse. It's very controversial. The Courage trial some years ago estimated that half of all cardiac stenting was clinically inappropriate. Controversial, as you might expect, among cardiologists. Well, I'm talking to Gary Kaplan. Gary's the internist who runs Virginia Mason up in Seattle. He's a center of excellence for Walmart. One of the main things he treats is mechanical low back pain. Walmart sends him patients that in their local communities have been selected for surgery for back pain, all right? Well, Gary has a rigorous process for addressing them. I'm going to show you a variant of it in just a minute. He turns back 54% of them. He told me just the other day, his current turn back, well, let's be more precise, turn back. He uses medical management for 54% of them. What he's really saying is that 54% of patients sent to him for surgery are clinically inappropriate. And by the way, he tracks outcomes in both categories. His medically managed patients get wonderful outcomes. So in terms of long-term outcomes, it proves out after the fact. He's saying that 54% of back surgery in the country is probably clinically inappropriate. That's what he's really saying, indirectly. Now, if you think number one is challenging to us professionally, number two completely overshadows it. What in the world could possibly be going on here? Number three on the list, November 30th, 1999, IOM Committee on Quality of Healthcare in America publishes a report called The Air is Human. I'm sure you're familiar with it. Within that report, we estimated 44,000, 98,000 preventable deaths each year in hospitals where the cause of death was not the patient's underlying disease, but the treatments we used to address those diseases. For each case, two separate independent physician reviewers examined the cases, agreed that the primary cause of death was the treatment, and also separately agreed that it was avoidable. Now, just a couple of points about this category. The first, on net, we add 3.5 to 7 years of life expectancy for every member of U.S. society, on net. The upside of the services we provide are dramatically bigger than the downside. You'd be an absolute idiot to stay away from care out of fear of these harms, seriously. Dramatically better benefit. You know, I swear though, nobody ever reads the second half of an IOM report except those of us who write the stupid things. I realize that they're 700 pages long. No reasonable person probably would, but I don't think anybody read the second half of that report. What we showed is hard science, demonstrated methods by which you could dramatically reduce that toll. 60, 70, 80% sometimes. You could take down those injury rates without losing any of the benefit. That was the point, is that we could be so much better, you see? I don't know, Don Barwick just sent me literally 2 days ago a review, somebody wanting to argue about the mortality rates associated with patient harms. What a waste of time. What an inappropriate argument. We shouldn't be arguing about how many people we're killing. We should be arguing about how we stop killing them. If you see the idea. Waste time and energy. And a difficult topic, by the way, because there's so much variation in how it's measured. It's really hard to get stable measures. Do you see the idea, though? It's a big opportunity, theoretic potential. Number 4 is a twist on number 3. Turns out we have a series of things that we know work. We know for a fact are effective. Treatments that are well demonstrated, usually randomized controlled trial evidence. It's usually been around for a while. They tend to be non-controversial. There's general consensus within the profession. Yep, we ought to do that. It was really Beth McGlynn who did the best work in this area when she was at Rand. She's now at Southern California Kaiser Permanente. She developed formal instruments, identified these different treatments. How well do we do? She studied 12 major metropolitan areas. She didn't want to get off in the sticks out in a rural area where there might be a lack of access to care. What she showed is that for adults, we managed to do it correctly 54.9% of the time. For children, 46% of the time. We call them injuries of omission. It's a form of what's called high reliability. Can we reliably execute for things that we know work and we agree that we should? All right? Turns out we can't. Well, here's the way to think about it. We routinely achieve miracles. That's a demonstrable fact. If we can achieve miracles doing it correctly roughly half the time, what kind of miracles could we achieve if we did it correctly all the time, or something close to all the time? If we could execute reliably on a broad scale. See the idea? It means for all the good we do, we're leaving a lot of lives and pain and suffering on the table. And the right way to think about it, huge opportunity. Now, if you take these 4, failures of clinical care, really, or how to say it, gaps between where we are and where we could be in clinical care, all of them have financial implications. When you use Ed Deming's models, he called it waste, where you have quality failures that drive higher costs. And that's what happens in these areas when these happen. Well, when you summarize that, what you get are estimates of how much waste there is in healthcare. Another IOM report. This was back in 2010. We called together the experts. One-line soundbite that people grabbed from that report. What we said was a minimum of 30% and probably over 50% of all money spent on healthcare delivery today is waste. From a patient's perspective, technically it's waste, non-value adding. From a patient's perspective. Now, I will admit that one person's waste is another person's income. I will admit that it defends itself politically quite vigorously through lobbying efforts with the Congress, things like that, you see. Here's what I'm really saying, though. Well, the truth in advertising part. I play in this sandbox a bit. When I model it, I'm going to show you my models, or at least the foundation for them. I get about 65% waste. This year, the United States of America is going to spend about $3.6 trillion with a T on healthcare delivery, this grand enterprise of which we're all a part. $3.6 trillion. I'm suggesting that somewhere on the order of $2 trillion of that is financial opportunity. Extractable waste. Now hold that thought, because when I'm crystal ball gazing at the end, I'm going to show you some very powerful clinical groups in the country who are betting their futures on exactly that. All right? And it's going to turn out to be a big driver moving ahead. Now, just in passing, most other countries can't measure waste at this level. They don't have the measurement systems in place. It has to do with the structure of their health systems. But when I take the rates at which these things happen, I argue that probably their waste rates are similar to ours, because their injury rates, their failure rates up on those, the gap size is roughly, give or take, plus or minus the same. All right? If you see the idea. I spend a fair bit of time internationally, but the reason is they see the same opportunities. They face the same challenges on a broad scale. It came from carefully measuring how we go about our business. It came from, well, what we call transparency. Now, when I say transparency, I want to use it a little bit differently than the government uses it. They like to rank physicians, rank hospitals. Turns out that's difficult. It's really hard to get precise rankings. Very often you get confidence intervals, if you're honest about it statistically, that span almost the entire range of the ranking. All right? You can't rank very accurately, if you see what I mean. I mean something differently when I say transparency. I'm in an environment where you, as you interact with the patient, can clearly see your actions and how they link to outcomes. That's what I mean by transparency, and it's a very different definition. Twice at IOM we studied this, and that's the definition we came up with, dramatically different from how the government sees it. So when that word pops up, you know my definition for the thing. Now, next thing, we know why this happens, a really short version. It turns out most of us practice medicine on something. In the literature, it's called craft of medicine, but it's the idea of personal excellence. It's what I described when I went to see a patient. It was high-quality care because these hands did it. All of my research background, my institutional associations, and my training and treatment experience. See that idea? So what you're doing, the way that Larry Weed, the inventor of the problem-oriented medical record and SOAP notes, the way that Larry said it is what you're really doing is you're taking this massive knowledge base that defines our profession and you're loading it into human minds, our minds. Carefully selected, really smart, very, very highly trained, expert physicians. So we load all that knowledge into our minds, and then we expect those minds to be able to apply it correctly to patients. See the idea? So craft of medicine, technically what it means, individual physician honoring that fiduciary trust to put the patient's healthcare needs before any other end goal. Then drawing on this massive knowledge base gained from formal education and experience over time. Well, the idea is we take them one patient at a time, and for each individual, we craft, and craft is exactly the right word, a unique diagnostic and therapeutic experience customized to that individual, starting largely with raw materials. And the promise we made as a profession is that this approach guaranteed each patient the best possible clinical result. And by the way, it worked. I said earlier we routinely achieve miracles. This is what produced those miracles. See the idea? Yeah, that's the basic model. You know, Einstein said it, though. He used to say it fairly routinely. He said it two different ways across his career. He said, today's problems are usually yesterday's solutions. He said, we can't solve today's problems using the same thinking we used when we created them. That's basically what happened to us. The same science that was making us so effective on behalf of our patients was making healthcare delivery increasingly complex. The ground shifted under our feet over time. The level of complexity of current modern medical practice is going up exponentially, dramatically with each passing day, month. You know, we're publishing over 20,000 randomized controlled trials per year today. There's somewhere between about 10 and 15 summary reviews per day. It's been well studied. I don't care how smart you are. I don't care how diligent you are. You can't keep up. It exceeds the capacity of the expert mind. The guy who first really showed this, by the way, just to give it its due diligence, is David Eddy. Eddie's a thoracic surgeon. He became so frustrated with why he was doing what he was doing that he went back to Stanford, got a degree in applied math, a PhD, started to study how we made these decisions. He's the guy who first used the word evidence-based medicine in the published literature, best that I know, 1990. He first used the term. Now, people like Sackett, David Sackett, Canadian physician working out of Great Britain, he and others popularized it broadly, and that may be a more important role. But Eddie kind of invented it, and he also invented all the formal methods we use in summarizing evidence for its application in clinical practice. So Eddie really is kind of the father of evidence-based medicine in that sense. Based out of Stanford University. Yeah, the way David says that the complexity of modern medicine exceeds the capacity of the unaided expert mind. He then proceeded to prove it, and that's what produces that list of opportunities. When you start to look at the details of that list of 4 areas where you could be much better, what really drives it is complexity. See the idea? Yeah. Well, go back to the waste models that I was talking about for just a moment. Here's the model I like to use about waste. It's actually 3 tiers, and it's got some really useful features. I think it's truly generic. I think it will handle any example of waste that you can name, I think. That's a disprovable hypothesis. But so far, it's worked out pretty well. It structures hierarchically, working from the bottom up, and it means that when you're analyzing total waste, before you say if you're doing things efficiently, you ought to not be doing things you shouldn't be doing. And so analytically, it's how you have to structure it to get a true estimate of waste without overlapping categories, so that's good. It links to payment mechanisms, which is coming up a little bit later. So I think it's a really nice way to model it. Down at the bottom, it's called efficiency. The way you think about it, you can divide care delivery up into what are called units of care. It's easiest to see in a time-derived activity-based costing system. So think of it this way. Every dose of a drug by route of delivery, each one's a separate little unit, separate little entity that I could give to a patient. Any imaging exam, by specific imaging exam, that's a separate little unit, each one. A lab test, right? A microbiology culture, an acuity-adjusted hour of nursing time, an acuity-adjusted minute in a procedure room. For some reason, I guess it's because of Shao at Harvard, we use 6-minute blocks of specialty physician time. But you can break out all these little elements of care, and then as you deliver the care, you can measure explicitly what you do. So the efficiency concept is built around that unit of care. Well, how much do I spend for that 6-minute block of the urologist's time? How much does it cost me for an hour of that medical ICU nurse's time? How much does that CBC run me for true cost? See the idea? Now, one way that you can take money out of a system down here is that I pay less for the medical ICU nurse. I pay less for the CBC. I figure out a way to do it more efficiently. The most common way is supply chain. By the way, this is where all the administrative inefficiencies also fall. They show up as what are called indirect costs loaded on to the cost of units of care down at this level. Well, bump up a layer. This is clinical variation within a specific case type. We spent a fair bit of time measuring this. Turns out that different physicians do the same treatments in very different ways, and it has big cost implications. Even when you carefully balance the patients coming in and the outcomes coming out, big differences, typically about a 2-fold difference in cost. We call that within case utilization. Technically, when I think in terms of units of care, how many units of care do I use of what type? So I'm taking these little granular pieces, and I'm using 4 of that one and 1 of that one and 26 of that one and 5 of that one, and I'm pulling it together into that cholecystectomy. See the idea? Or that clinic visit for type 2 diabetes mellitus. So I pull them all together. Well, this is also where patient safety fits, interestingly. What happens when a patient has a safety event is nearly always you end up consuming more care in recovery. Then top of the list, this today is what's called population health. How many cases do I do? All right, it has 3 major subcategories to make it a little bit more real. We talked about inappropriate care, back surgery that just shouldn't be done. Well, what if we only did back surgery for patients who would have a clear clinical benefit? What if I reduce the use rate by 50%? You see the idea? There's another chunk, it's called preference-sensitive cases. It's mostly surgical procedures. This is a Dartmouth idea, actually. Hips and knees would be a grand idea. What they showed is if you had formal mechanisms, validated, balanced presentation, that when patients really understood what that artificial joint, elective artificial joint was going to mean in their life, use rates fell by about 40 to 60%. I'd rather live with the pain than actually go through the procedure. See that idea? So this is David Wenberg particularly, who's now up at Maine. The last one, avoidable cases. It's called hot spotting or move upstream. I didn't include this slide. We moved to a 3rd-generation patient-centered medical home, published this in JAMA 3 years ago now with our little group here in Utah. We reduced hospitalization rates by 22%. We reduced specialty referral rates by 21%. And what you're doing was dropping into our primary care setting and delivering much better coordinated primary care. And because of that better care in a primary care setting, patients didn't need to be hospitalized, a clear quality gain. But it means you avoided the cost of the hospitalization. See the idea? Now, when I model it, the total waste bucket for me breaks out roughly this way. About 15% comes at a supply chain level, administrative inefficiency level, about 40% at a clinical variation level, about 45% up at a population health level. That's just to show you the breakout of where the money lies. On the other hand, don't get too distracted by this. At Intermountain at the time, we were taking out about $20 million a year from supply chain, being more efficient in purchasing. So it can be serious money, at least for a big system. See the idea? Well, I want to show you a clinical example. Technically, it's this one right here. Inappropriate cases. Happened here in Utah. It was led by Don LePay at Intermountain Medical Center originally, so credit to Don for leading this. What you're going to see is an attempt, a conscious attempt to address complexity. All right? That's what this was. So, yeah, it happened in cardiac services led by Don LePay, cardiologist. Really 4 areas, I guess 5 if you break those out. Stress testing, angioplasty and stents, permanent pacemakers, defibrillators. Well, it's a bread and butter, major source of income for a typical hospital. Certainly true for Intermountain Medical Center, you see. Well, Don started to wonder if all of the cases that came through the cath lab at IMC were clinically appropriate. He knew it was a complexity problem. The number of factors, well, here's how he did it. I guess that illustrates this as good as anything. For each of those areas, he took the American College of Cardiology indications guidelines and reduced them to a paper form. They ranged from about 40 factors to as many as about 90 factors. But he managed to cram them all on one sheet of paper. Sometimes he had to use the back, all right? He went to his colleagues practicing cardiology at the facility and said, guys, before you do the case, would you please just check off one or more evidence-based indications? Now, just a couple of side factors on this thing. Number one, when I looked at him as a crusty old quality surgeon, my response was, Don, all that I can say is the ACC sure is kind to you guys. Best I can tell, the cardiologists kind of look out for the cardiologists. If there's a question about whether it might be beneficial, you usually err on the side of let's do it. All right? I think if I were generating them, I'd be a lot tighter. But it was acceptable to the cardiologists. What the heck? Let's just go with what we got and what's acceptable. The second thing you need to know, here in Utah, well, this particular group was already one of the lower use rates in the country. We're in the bottom quartile of the country on population-based rates. By any external metric, we weren't overutilizing. We were one of the go-to exemplars, in fact. He also did some things to make it more attractive. The main one, he worked with the insurance companies. It turns out that if the cardiologist would just check off one or more indications, it was pre-auth. And it took what was a fairly burdensome procedure to get pre-auth for one of these procedures and reduced it to a few seconds worth of work. If you see the idea. It's all paper-based, by the way. Don would take the papers, he would scan them into the EMR. It's just a scanned document. Then he actually used my interns, young people trying to get into medical school who worked for me, and I'd have them converted into coded data so that we could actually analyze the stuff along the way. Ran it for several years. See the idea, though? What's he doing? He's getting the evidence as put forth by a professional society, a respected professional society, in front of the clinician at the point you're making a decision. That's the key to this. Some awfully good people in these groups. Oh, what happened? Use rates fell by 22%. That's interesting, guys. Now let me get this straight. This is one of the lowest use rates to begin with in the country. When we get the evidence in front of the docs at the point in time they're making decisions, it falls significantly. comes down fairly dramatically. Oh, he was tracking long-term outcomes. Guess what? Long-term outcomes improve slightly. Turns out in incapable hands, the risks associated with these procedures are relatively low, but there's still some risks, aren't there? And it means that he was not exposing patients who would not have a commensurate benefit to these risks. It was sobering. It was humbling. As a caring physician, to realize we thought we were the best in the world. And frankly, we were by any external metric, but we could be better on behalf of our patients. That's what you learn from this. What you learn is the limitations of the expert mind. And you learn that it's possible to put tools in place that will make us better. It doesn't change your goals. It doesn't change your heart. It just makes you better in doing the things that you want to do anyway. It has some financial implications, you might imagine. This is just variable costs, fell by $19 million a year. If you get the fixed costs in with it, it's about a $40 million a year reduction in total cost of care. That's fairly serious money, you see, for better care. So what you're seeing is this right here in a good state-of-the-art practice carried to the next step by addressing the core problem of complexity. That's what you're seeing. And sure enough, the care improves, and sure enough, money comes out, waste comes out of the system. See the idea? Well, wait a minute. Imagine at the time I'm Moody Chisholm, the guy who's the administrator for the hospital. How does Moody feel about this? Yeah, we just took one of his major cash cows and, chopped off a leg, didn't we? Suddenly his revenues are down. How's he going to keep this practice enterprise, a hospital, up and running when we're doing this kind of stuff to him? See the idea? Now, the key takeaway is nearly always better care is cheaper care. Another way of saying that, if I were wearing my administrative hats, the path to financial success leads through clinical excellence, guys. And that's one of the principles, the fundamental principles that emerges from this. Financial success depends upon excellence in clinical care delivery. All right? That means us. It means people in this room. That's what it means. The trouble is quality is not really free. There's a guy named Phil Crosby who wrote these 2 books called Quality is Free. He was kind of getting poetic. It's not free. It takes a fairly substantial investment. Data systems, right? I described some of what LePay had to go through to make it happen, negotiating with the insurers to get them to accept this kind of pre-auth. There are all sorts of investments you have to make it happen. The reason that Crosby can say quality is free is you get this massive return on investment. 5-fold, 6-fold, 10-fold returns on investment many times by taking waste out of the system, if you care to see it that way. Big money to be had out of this thing, right? But here's the real question. Who has to make the investment? By the way, it's nearly always us. It's pretty much always the care delivery group who has to make the investment to make it happen right. Well, wait a minute. When you take the waste out, who gets the money? Do you get it back to offset your investment, hopefully with a little to invest in the next project or to help you moving forward? Well, that depends on how you're paid. Same model that we had before, efficiency at the bottom with in-case utilization, population health case rate utilization, then play that through. This is, by the way, our little article we published in All Crazy Places, Harvard Business Review. Fee-for-service payment versus per-case payment, DRGs. I've labeled this provider at risk. There are 7 or 8 forms of it. In the extreme, it's called capitation. All right? It's today what's called, in policy circles, pay for value. Pay for volume, fee for service versus pay for value. A little red down triangle means that while you had to make the investment, some insurance group got all the savings. The way I think of those insurance guys, I imagine them, this may not be accurate, but it's fun. It's this fat cat sitting behind this big walnut desk, and they just come and dump bushels of money on his desk. I mean, hundreds usually, $100 bills, and it's his job to sort them and bundle them and store them away. Was it their idea about how to make the care better, how to take out the waste? Good heavens, no. Did they invest in it and support it and make it happen for better patient care? They're so far away from it they can't even see it at a distance. They just sit and count the money. See that idea? I've just described to you the primary reason why healthcare delivery is moving to that right-hand column. Pay for value, providers bearing financial risk. It's where your financial necessities align to your professional commitments. That's where it happens, is in that right-hand column. All right? Yeah. Well, with that as background, what does the future hold? Now, guys, this is crystal ball gazing. I'll almost certainly get it wrong, but I'll tell you why. I have what I call a series of forward-looking indicators. And I wanted to run them with you just so you'll get a sense of why I'm going to make these statements. Number one, the one large group in the country that's already fully financially aligned is Kaiser Permanente. You know that those guys have been growing by leaps and bounds, not by geographic expansion into new markets. The whole thing in Seattle where they picked up group health was a bit of an anomaly. They're out-competing others in their markets. They've gone from a basically $70 billion system to $90 billion over the last 3 years. They've shown dramatic growth by increasing the number of patients they see. And what they're using is an aligned pay-for-value financial model to drive that whole thing. It means they can offer price differentials. They're cheaper. I know that there are questions about their quality of care, level of service associated with their system, but believe it or not, that lower cost seems to overwhelm that. And by the way, they're working awfully hard on those perceptions of quality in care and patient experience of care at the same time. Work with them a bit, and it's booming, to say the least. Medicare Advantage and ACOs, they're really the same thing at one level. Both of them are ways of easing in to provider at risk without going all the way, but easing into it. This slide shows how Medicare has been shifting. The blue line is Medicare fee-for-service. You notice a trend? Where are all those Medicare patients going? They're going into Medicare Advantage and ACOs. And that trend we think is going to continue. Currently, less than half of all Medicare is fee-for-service medicine. And it continues to decline. So you're moving into a pay-for-value, provider-at-risk world. This one's really fun. I've encountered it in a number of communities. What it is cut out the middleman, get rid of the insurer, more or less. Currently, 11% of large employers, their ERISA plans, where you're self-insured for your health care benefits as a large employer for your employees and their families, are contracting directly to a care provider network without an insurer in the middle. What it means is a shared savings model where the care providers and the corp payer, the original payer, the business, are in it as partners together. Turns out that the major things that insurance companies do, if you can form a network that supplies a full range of services, that's the hard one. But if you can put together a network as a care provider group, everything else an insurer does is a commodity. You can buy them in the marketplace for not much money. That's a fun discussion on the side if you're interested, of the specific things they can do and the fact that you can buy them. But it's growing at double-digit rates. And what it is a shift into pay for value. Another one of my forward-looking indicators. It's why I believe that it's moving. So I'm up at Bozeman, of all crazy places, Bozeman, Montana. Montana State University is a big employer in town. Talking to John Hill, who runs Bozeman, he says, well, you know, the guys over at Montana State have approached me about, are we willing to go into a shared risk model for their employees, perhaps even their students down the road? See that idea? Happens all over the place. This last one is really fun. So you tell me, who's the largest employer of primary care physicians in the United States today? Do you know? Turns out this group is over 30,000 employed primary care docs, pushing up on 40,000. Who is it? It's Optum. It's one of the arms of United Healthcare, the big insurance company. United Healthcare is investing billions of dollars in primary care. I've spent a fair bit of time with their senior leadership. I know exactly what they're trying to do. It's that move upstream strategy. It's the idea of primary care-based, team-based care dropping hospitalization rates by 22%, dropping specialty referral rates by 21%, dropping ED use rates by something like 12%. They're quite explicit. They understand that the insurance model cannot continue to pay off the way it has in the past. They're moving upstream in the care delivery process. They're not buying hospitals, by the way. And they think that they can use this to continue to pad their bottom line in the stock market by taking those resources out of hospitals. And they're moving ahead fairly vigorously with it. I'm not sure it'll work. It means they have to be able to manage primary care. It'll be really fun to watch the fur fly on this one, to see how it works out, to see if they're competent to make it happen. But that's what we see happening. Now it's funny, I travel the country. It's very community specific. So I'm at Unity Point. They're the old Iowa health system. They're based out of Ames, Iowa. They have about 26 hospitals, I think, something like that, a bunch of clinics, 3 states back in the Midwest. They're over 40% at risk contracts right now. I'm at UPMC, University of Pittsburgh Medical Center. They're Western Pennsylvania. They go up against Allegheny Health fairly heavily. They have their own health plan. They're about 45% at risk. The tipping point's about 25%, by the way. If more than 25% of your care you bear financial risk, you make more money by doing move upstream strategies on your at risk than you lose on the fee for service. I mean, forget the ethics, just pure money. It's right around 25%. They're way past that. It's in their rear view mirror and receding. You see, I'm out at Hawaii Pacific Health. I'll be there this Friday again. Melinda Ashton's their chief quality officer. They have a big monopsony. HMSA is the Blue Cross Blue Shield nonprofit, but about 80% of the commercial market. Ray Thomas, the guy who's their CEO, is taking about 100,000 lives from HMSA, and he's going full capitation. And the reason is under Melinda's leadership, those guys are really good at managing the care. Not where an insurer is managing the care, but where the care provider group is managing the care. Fundamentally different definition of managed care. And the list just goes on. And you see it happening and advancing around the country. Hence, you've got my crystal ball. I think this stuff is unstoppable. But the real reason I think it's unstoppable is it's got $2 trillion of financial opportunity lying behind it. And I think I'm seeing the future. At least I've managed to convince myself of that. Trouble is I drink way too much of my own Kool-Aid, but you can be the judge on that. Yeah. By the way, this is the reason the ERISA plans are shifting. This is a really interesting slide. What this shows down here is utilization rates for services. The orange line is inpatient. Utilization for inpatient, the population level is dropping. The black line is total. The yellow line is outpatient. The green line is pharmaceuticals. But what we see happening, if this is number of units, the little model I just showed you with units of care, this is the cost per unit. And so what we see are groups are spiking their charges for each of the things they do. And of course, if you take number of units times cost per unit, you get total commercial insurance prices, you see. And by the way, pharmaceuticals are the bad boy on that slide. They deserve what they're getting, best I can tell, and should get some more. I mean pain and punishment along the way. This is why large employers are shifting into a new model where they get to set the prices basically through negotiation. See the idea? Yeah, well, what I think we'll see, increasing focus on waste elimination, just so much value in play. The cool thing is, the real driver, it comes from better care. You achieve it by demonstrably better clinical outcomes for your patients. It's what brought us all into medicine. It's what should drive us every day. It's the clinical heart. A appropriately expressed, the care of the people who seek our help. As we do it better, it drives out waste. Your financial success, doctor, depends upon your clinical success. You see that idea? That's the principle that emerges from this. Well, the trouble is the payment side. That will cause good care delivery organizations to increasingly seek capitated risk. And really watch out for this payer care provider consolidation like we're seeing with Optum Health buying primary care, insurance companies partnering like you see with UPMC or others. That's what will happen to HMSA in Hawaii too, is they're starting to partner with care providers rather than letting the care providers go around them. And so they're consolidating together. So it's not hospitals coming together as a group to fix prices, not what we call horizontal consolidation. The fun part's the vertical consolidation. And that's really interesting. If you're left behind, if you're a standalone specialty care practice or hospital, you become something called a price taker, where it's a race to the bottom on how much you get paid. Metrics for quality, and it's just how cheap can you do it? Because that will determine if you get the care. It's price. And I'm suggesting you don't want to be down here. You want to be somewhere up here is what I'm suggesting to you. Well, one last idea that I think is really appropriate to this community at this time. So a question for you. There's a strong research base behind this. It's relatively new. It has to do with physician burnout. You've seen the literature on physician burnout. You've heard the stories. You've seen the cases. Well, it turns out there's this one factor in care delivery. It's the single most critical factor that determines it's very strongly associated with clinical quality of care. It also is a primary contributor to patient experience of care, and that patient experience drives perceptions in the community. Think of it as backdoor advertising, dramatically more effective than anything you can put on the TV or on social media or in the newspapers or in direct mail on the radio. By far, 2, 3, 4-fold more effective in attracting patients to your door, all right? When you really get that patient experience of care clicking. It's associated with productivity. Not just 2-fold increases in productivity of your workforce, but sometimes 4- and 5-fold increases of productivity. It's amazing when you look at it. And of course, that means it's going to drive your financial performance. What is it? What is this factor that is so centrally critical to long-term business success within a clinical enterprise? What is it? Turns out it's medical staff and workforce engagement and morale. The opposite of burnout, if you will. Now, the world's expert on this, it came out of Mayo. His name's Steve Swenson. Steve was their chief quality officer. He's a radiologist, but we'll forgive him that. He was their chief quality officer, a really smart guy. He went on to be their head of leadership development for Mayo. A very strong organization this way. His is usually the senior author spot on all those articles that have been coming out lately, but it's his group that's been producing all that research. The funny thing is Steve just retired from Mayo. He's a very avid skier, Nordic skier, downhill skier, and he just built a house in Heber. So Steve now lives in Heber, and I regard him as probably our country's, our profession's #1 asset for understanding this particular factor. So just one idea. He has a book coming out in October through Oxford University Press called, I think, probably be called Burnout, he says. But it's reviewing the evidence around this. You know, it's funny. One of the last guys you'll meet who actually learned quality theory from Ed Deming, Dr. Deming used to talk about joy in work and drive out fear as key elements of a quality organization. He had the ideas, but Steve Swenson gave me the nice left brain system for making it happen. It's the first time I've really seen it at this level, and I'm pretty jazzed about it. So a little call out for Steve. I think it's going to be pretty, and I think it's way good that he's in Utah right at the moment. We have a wide disparity of organizations delivering care in Utah in terms of physician engagement. We have some that are actually some of the worst in the country here. We have others that are up close to the top, but we have the wizard who can help with it, and I'm really hoping it will have some differences in our community. I think it ties in. Well, with that, ladies and gentlemen, my professional colleagues, I'm done. You've seen my gaze of the crystal ball. I'd be very interested in your opinions. I'm kind of jazzed about our future in the following sense. I think we're going to be way better than we have in the past. I mean, it's not just the technology. We just got through hearing about 3D printers. Wow, that stuff is cool. Advances in therapy on a broad scale, they are accelerating the tools that we have available to help people. But more than that, how we, us in this room, not just as receivers of this, but as the people who actually deliver the care, better ways of executing the things we want to accomplish. And it's so exciting to see it happen. I think what we've achieved so far is a mere down payment on what we have to offer to society and to the people who seek our help. Can you think of a better time to be in medicine, frankly? I realize it's trying to live through this kind of change, but we're going to create something like the world has never seen. I personally count it as a true privilege to have been in the profession of medicine at this point in time. You ain't seen nothing yet. The power for this lies in this room, not in Washington. It lies in this room, and it's going to be one heck of a ride that we'll look back and say, wow, I was privileged to be the best profession in the world as we dramatically improved what we do for those who seek our help. With that, thanks for your time and attention. We have a couple of minutes for comments and questions, I think.
Apropos of your curve that goes up with pharma expenses,
This guy right here.
my experiences have been that a lot of extra cost comes from dictated formularies. And do you have any suggestions for the physicians here in terms of how we can contribute to getting that out into the sunshine so that we can get rid of it and go back to some of the medicines that aren't on the formularies anymore because they're getting a bigger kickback from the new
I'll
drugs?
apologize, I don't. You've said the key word is transparency. I'm really hoping, so this is a hope, guys. This is one where policy, so when the Democrats and the Republicans have now lined up to do something about pharmaceuticals, it's when 44 states are taking a number of those pharmaceutical companies, including big guys like Pfizer. Those are criminal charges. This is serious stuff. They've already had some of those executives plead, to criminal misconduct. And I think they're going to get slapped silly. We also have from here in Utah, now I always forget its name, it's that new generic pharmaceutical company that Dan Lillenquist really let out, based out of Intermountain. It was called Project RX, but it has a new name. Yeah, you'll see responses like that. So the change is starting. It's far enough out of my field, though, that aside from watching the fun from the outside and cheering on the underdog, and I don't know what else to tell you. So next person.
My question is more, I feel like I'm trying to transfer blame here, so I want you to help me.
Sometimes that's really useful.
The thought, the flaws in my thinking here, but I'm in primary care, and as I listened to your talk, I kept thinking, boy, I have to order a lot of inappropriate MRIs of the back to make a dent in any of this, compared to one inappropriate
surgery,
cath lab or back fusion or anything like that. And so, I look at this and I think, yeah, I'm not the fault here. It's not my kid causing the fight on the playground or whatever. And so
he just bought the biggest stick, right?
So help me know where I'm wrong here.
So here's a different way of thinking about it. What I hear you saying is two different things. Some of the opportunities are dramatically bigger than others, and you're absolutely correct. And when you're wise about how you approach it, you get the big guys first. This is one of my main complaints against choosing wisely. They pick teeny little stuff, right, as opposed to the big heavy stuff. And you'd really like to do the big stuff first. On the other hand, the opportunity exists in every aspect of clinical practice. Your primary care practice, orthopedic surgeon's practice, oncologist's practice. Oh, by the way, variation in nursing services is at least as high as variation in physician services. Most people don't appreciate that. So it's the healing professions in general. All of us ought to be working on it, is the idea. The other trouble is we know the tools that allow you to address it. They're tools that allow you to better deal with complexity. And what I know is for you to do that by yourself as a solo guy in your own practice, dang, that's hard. You need to group up either with professional groups, so the ACC is what Don LePay used, right? Or with a care delivery organization, you know, a big clinic, let's say, Tanner Clinic, somebody like that could do this, but it sure makes it easier to deploy. If you think about it, though, as you just think about your practice, the way I'd be asking the question is several parts. The first thing is are there things in my practice that I think I could improve? The second question would be, what are the tools I'd use to make it easy, simple, straightforward to do without trashing my clinical productivity? And there are, but I'd have to track those down. Then the third thing you got to be thinking is, how do I turn it into, I'm going to do good in the world, how do I get some return on investment so I can afford to do this for the next guy? See the idea? But there's things that everybody in this room could be doing along these lines. And if we all did it, that'd be sweet.
I've been impressed with your rational and scholarly approach to medical care. How does that jibe with the political approach that we hear in these campaigns? They don't seem to be involved with any of the analytical processes that you've just discussed.
Over the years, what I've learned is, you know, I spent a fair bit of time in D.C. It's mostly a waste of time. It's kind of fun. You get a certain amount of reputation for doing it. What I've learned is that the core of this problem is right with us and our profession, right? And I think that medicine really does lead on this one. What I said that the power to change this lies in this room, I really meant that. I don't think that you can change it at a policy level. Oh, they can do things that will screw things up, but that's about it. There's a very limited set of things that the Senate Finance Committee or the Congress can do compared to what we can do. You see? It's the most fascinating thing when you start to really track this down. What it does is it puts the medical profession back in control. That's what it does. Now, I need to say that in a very careful way. Profession as a group, not as solo individuals. But boy, when we stand together as a profession with the right goals, with a clear understanding, the right diagnosis of the underlying problems and the treatments that are available, wow, we can do great things. And I prefer to spend my time with groups like you because I think that's where the change will really happen. And so I regard, you know, it's interesting. So I moved to Boston. The first year I moved there, they had a circumstance kind of like Utah. The Democrats control the state government. They dominated the state legislature. They would go into political caucus, make decisions, come out and just pass legislation with no debate. Boston Globe, one of the most liberal newspapers in the country, recommended that they would not allow high school students to go watch the state legislature in action because it was such a poor example of good civics. They had that kind of dominance, right, in their state. Well, that year, the first year I was there, 3 major court cases that sent people to jail. It was all people in the legislature, usually lame ducks, giving big contracts to family members or somebody, a friend, through legislation. There was the guy who got a contract from state of Massachusetts Commonwealth state government. He was supposed to be hauling fill out and dumping it in the bay to extend the land at Boston Harbor. And it turns out he was taking the money, but he wasn't hauling any dirt. And if I read it right in the Globe, his primary defense was, first of all, it was a make-work project, and that by not hauling it, he was reducing traffic congestion and pollution, and that he ought to be given credit for not doing it. Well, he took the money. Well, you see the idea? And I said, guys, the Globe was running a tally of waste in state government. And at the time, now this was back in the 80s, it's up over $300 million of this kind of spending, according to the liberal newspaper looking at the Democrats. Now, by the way, it's political power concentration is the underlying mechanism here. So you shouldn't be picking on the Democrats too hard. Could be another group in the wrong settings. Could be another group. Well, yeah, what one of my friends explained to me is he said, you're thinking about it wrong. He said, politics is really part of the entertainment industry. He said, you ought to be thinking of this as entertainment and think of it as your dollars, your tax dollars, buying some just really classic entertainment. I realize it's fairly expensive, but what great entertainment. And it's stock. And when those guys go through all their machinations, I look at it mostly as entertainment. No substance. Now, they can screw things up pretty badly from time to time, but their ability to do true good is quite limited as compared to a group like this. So that's just me being silly. A couple more, or where are we?
Maybe one more question, and I think we've got to move on. We've got some other things.
We got food waiting, guys, and I can't believe you'd listen to me as opposed to going to get some food, so.
Have you looked at the relationship of electronic medical records systems and their algorithms? And there are probably over 200 or 300 companies that make electronic medical records systems.
There's six
in the
big
cost in the things that you were talking about.
I have. The trouble is you're tempting me to get up on one of my favorite soapboxes. I can go completely crazy on this. I believe that the current set of medical records is probably doing, well, they're doing a significant amount of damage. They're designed primarily for fee-for-service billing. Their primary purpose, they're purchased by administration with a primary purpose of documentation to support fee-for-service billing. And they do an extremely poor job of supporting clinical care delivery. All right? No question about it. All right? So I'm talking Epic, I'm talking Cerner, Meditech, Allscripts. Those are the big dogs. I've seen some new ones that are actually designed for a doctor or a nurse delivering care, and they are sweet, and they fit what I've just described to you. And by the way, the funny thing is they do a better job of billing, too. What if the clinicians design those systems instead of a bunch of administrators? All right, so apologies for the soapbox, and thanks for your time and attention, guys. Hope you have a great meeting.